Chapter 33, Pediatric Emergencies. So in this chapter we're going to discuss the A&P of children, how it's different from adults. We'll talk about the physiologic and psychologic characteristics of children. We'll talk about how to interact with kids and do their assessment and how to talk to their parents or caregivers. We'll talk about pediatric assessment and how to detect and treat special concerns regarding ABC, shock, etc. We'll talk about a few pediatric medical emergencies. We'll talk about pediatric trauma and how it's different from adults. And then finally, with child abuse and neglect. And just to note, this will be broken into 2 videos. This will be part A. So first, developmental characteristics of infants and children. So we separate kids out into these categories, realize that this is a continuous development stage, right? But we like to categorize things, so we put them in categories. So newborns and infants, this category goes from birth to 1 year. Toddlers from 1 to 3 years, and that is about when they start walking at about a year. Preschool 3 to 6, and then school age 6 to 12, and adolescents 12 to 18. So there are significant differences in their psychology, anatomy, and physiology. So kids aren't just little adults, and we need to take that into account when we care for young patients. So 1, their head is proportionally larger than the rest of their body, and if you have them laying flat, you often need to put a pad underneath their body in order to get their head to be in a neutral position. The child's nose is smaller, has a smaller mouth. The tongue takes up proportionally more space. Their trachea is narrower, and their cartilages around there are less developed, and with that smaller airway, those airway structures are more easily obstructed. In their chest and abdomen, their abdominal organs are a little bit more elastic, less secured in there, and they're more prone to internal injuries, especially during things like car accidents and stuff. They tend to be more abdominal breathers, and so you'll see their abdomen going in and out more often, especially with the infants in that category. Their body surface is larger in proportion to their mass, which means that they can lose heat quicker, basically, and gain heat quicker too, for that matter. But it makes them more vulnerable to hypothermia. As far as blood volumes go, they have obviously less blood volume than adults, and so if they lose the equivalent amount of blood, that's more significant for a kid than for an adult. So how do we interact with kids as medical providers? So 1, identify yourself, tell them who you are and what you're there to do. If their parents aren't there, make sure that the child knows that someone is calling their parents. As long as the kid is not dying right in front of you, then keep it a nice, calm pace. You being calm and not freaking out will help them be calm. If they're young enough where a nearby toy would be helpful, then fine, let them have a toy. That is just fine. Don't stand over a child patient. Keep down at their level, so kneel down. Try and smile, be as friendly as you can. If you hold their hand or foot, that's fine. Don't just bring out some scary looking piece of equipment without telling them what you're going to do with it. Don't stand behind them and talk at them. Address the kid when you're sitting in front of them or kneeling in front of them. stop to make sure every once in a while that the child knows what's going on. Don't lie to them. Don't tell them that things aren't going to hurt if it is going to hurt. It's hard to rebuild that rapport. And then let's talk about the parents. So it's a bad day if you have to call EMS for your kid. So realize that the parents are going to be freaking out and probably not knowing what to do, unless it's some kind of chronic disease that they know what they're dealing with. So they might worry and think that they're being bad parents themselves somehow. If it's an accident or some kind of trauma, they're going to be maybe hurt themselves, but probably more worried about their kids. And sometimes that goes poorly, and them freaking out makes the kids freak out more. In general, though, keeping parent and child together is probably the better option. There are exceptions, but in general, that's the best. Okay, pediatric assessment. Similar to adults, but there are some differences. So we kind of simplify things down a little bit to this pediatric assessment triangle. So we're looking at 3 different things. So when we walk in the room, first we're looking at their appearance and just how they look like they're doing. So this is similar to a general impression for adult patients, but we're looking at tone, how interactive are they, what's their gaze, are they paying attention to what's going on, or are they just zoning out, are they crying, or are they inconsolable? And then we'll look at their breathing and see how well they're doing there. So listen to breath sounds, look at positioning, are they in tripod position, look at retractions, do you see sternal retractions or subclavian retractions, nasal flaring, and then look for signs of circulatory issues. So skin tone, pallor, are they really pale? Are they mottled? Are they blue? Is there any bleeding? So the idea here is that you rapidly identify a critical patient. Because if any of those things is off, then that's probably a critical pediatric patient. So general impression of this kid is probably okay. Skin tone looks decent. Looks like he's looking at his toy. You'd have to probably watch a little bit of a video to see if he's paying attention or not, or just staring off into space. So for kids, we do AVPU, same as for adults, but for kids, we're not going to do a real like sternal rub. We're going to do tap their feet for the painful response. Assess their airway. If they're crying, that's usually a good sign for us. That means their airway is open and everything is going in and out. But go ahead and make sure that they have an open airway. Look at their breathing. Do they have any of these signs? Altered mental status, flared nostrils, pale or bluish lips or mouth, stridor, grunting, a very fast breathing rate. Remember that kids are going to be breathing faster than adults normally. So in this one it says breathing rate greater than 60. That's going to vary with the age of the kid. Retractions, so look in between their ribs. Is the muscles getting sucked in there? Do you hear any breath sounds? Does it sound like they're wheezing? Look at circulation, look at their skin tone. You can check cap refill. And then if you find a kid is high priority, then we're going to transport. So we're not going to fix them out there. We need to transport. After you get your primary assessment done, you can do your secondary assessment. So for kids, or for adults, we usually start and do a head-to-toe exam. For kids, we're going to do a toe-to-head exam. If the kid's pretty young, in the parent's lap is a decent place. Older kids especially, you're going to want to protect their modesty, so don't do a strip off the clothes kind of exam in a public space. When you do need to remove clothes, just make sure you're explaining why you're doing what you're doing. With real young kids, remember they have those fontanelles up in their heads, so you don't want to push on those soft spots. But if you can look at them and examine them, then you can see whether they're bulging, which might be a sign of some kind of meningitis, whereas a sunken fontanelle might be a sign of dehydration. Look in their nose, make sure that's not all full of something where they can't breathe. Make sure there's nothing come out of their ears, like they have a head injury. Look at their neck. Kids' vertebrae especially are real small. Their heads are really big and heavy compared to the rest of their body. So it's pretty easy for them to get neck injuries, especially crashes. When the time comes, if you don't have a reliable open airway, then you can do oral airways. We typically don't have nasal airways the size for pediatric patients. Look at their chest, listen for lung sounds, listen for especially wheezes, anything like that. Make sure both sides of the chest are going up evenly. Look for any bruising, any paradoxical motion, any retractions. Check their abdomen. We're going to palpate their abdomen just like for an adult. Squeeze their pelvis a little bit, make sure that it's not broken. And then on each extremity, feel down for injuries. Check cap refill. If you can do a distal pulse, that's good. For the real small guys, remember, we're going to do brachial pulses on the arms. Make sure they can wiggle their fingers, wiggle their toes, feel you touching. Assess their mental status. We're not going to ask necessarily the same exact questions for kids. You got to tailor that a little bit. To adults, depending on the age of the kid, they're not going to know the day of the week and stuff like that. But if you can get them to say where they are, and what's going on, and their name and stuff, then they're probably doing pretty good. Make sure to maintain an open airway. Most problems with kids are going to start with airway problems. Keep monitoring that skin color, temperature, condition, reassess vital signs. It's going to be hard to get blood pressures, especially on the real little guys, and it's not as important a vital sign to get for the smaller kids too. Okay, airway concerns. So we always need to maintain open airways. We're going to use the same maneuvers, head tilt, chin lift if no trauma, jaw thrust if there is trauma, suction. Remember that tongue is proportionally larger in their mouth, and so it's easier for it to fall down and obstruct that airway. So we do have oral airways that are sized down to pretty much the smallest kid. But we're generally not going to be using these until we get to the point of CPR on a kid. NPAs for the larger kids, so these are probably the 12 to 18 range, is where we're going to start having NPAs that might get in a kid's nose. So airway obstruction is one of the more common emergencies for a kid. If they're able to move air, so if they're talking or coughing, then it's a partial obstruction, and especially you might hear like stridor with that upper airway obstruction. So give them oxygen, put them in position of comfort. We're going to transport and then let somebody at the hospital try and get whatever it is out of there, or relieve like the asthma or something that's causing the obstruction. If it's a complete obstruction, then we're going to do something like the Heimlich if they're awake. Otherwise, we're down to CPR. For real little guys, so somebody that's big enough that you can pick them up on your arm and do this, you're going to do 5 back slaps followed by 5 chest thrusts until that object is out of there or until the patient goes unresponsive. If they do go unresponsive, then you're down to doing CPR, with the one difference that when you're checking in the airway, making sure it's open to give breaths, you can look and see if you see an object in there. If there is that you can grab, then you can get it out, but we don't do blind finger sweeps. Kids don't necessarily tolerate masks very well. You can just hook up some oxygen tubing to the O2 bottle and then do blow-by O2 here. So if you set it at 6 or 8 liters and just shoot that at their face, they'll get more oxygen than they otherwise would. Remember to use the right size mask. We do have pediatric size non-rebreathers, pediatric nasal cannulas, and pediatric bag valve masks. Remember that their little lungs don't need nearly as much air, so use the right size BVM. If you're doing resuscitation with a pocket mask, then make sure you're not blowing too much into their lungs. And we're going to stop it here, and I'm going to switch over to the next lecture, to the next section of this one.